Warm welcome to everyone. This is our our 50th seminar hosted by the Centre of Research Excellence in Aphasia Recovery and Rehabilitation. My name is Dr. John Pearce and I'm a postdoctoral researcher at the Aphasia CRE and facilitator of these seminars. Before we do anything else, I just want to pay tribute to the traditional custodians of the lands on which we live and work across Australia. I'm on the Bunurong land right now, and the CRE sort of main office is located on Wurundjeri land, and we pay our respects to their elders past, present and emerging, and extend this respect to all Aboriginal and Torres Strait Islander people attending today's seminar. Pleasure today to be welcoming Dr. Will Evans to speak to us on acceptance and commitment therapy for aphasia. I will introduce Will in just a moment, but first I'll just explain how you can ask questions throughout this presentation. If anyone who hasn't attended one before, you are welcome to submit questions to Dr. Evans using the question and answer button in the Zoom toolbar at the bottom of your screen, but please don't use the chat function because I won't be looking in there. And you can ask questions at any time, and this allows other audience members to indicate their interest by liking the questions they would also like answered, and I will start by asking those most popular questions in order. So please ensure you ask questions fairly brief, concisely, and avoid submitting comments. We'll leave aside sort of anywhere from 5 to 15 minutes to answer questions at the end of Dr. Evans' presentation. And without further ado, I'd like to welcome and introduce today's speaker, Dr. Will Evans. William Evans is an associate professor at the University of Pittsburgh in the Department of Communication Science and Disorders, with a joint appointment in the Clinical and Translational Science Institute. He completed his undergraduate and graduate training at UMass Amherst and Boston University in the areas of psychology, linguistics, speech-language pathology, and speech-language hearing sciences. He's also practiced clinically as an outpatient speech-language pathologist at Massachusetts General Hospital and the Pittsburgh Veterans Affairs Pirate Intensive Aphasia Program, specializing in aphasia and cognitive rehabilitation. At the University of Pittsburgh, he directs the Language Rehab and Cognition Lab and is a member of the multi-PI Pittsburgh Translational Aphasia Research Initiative. He teaches graduate coursework in the areas of counselling, aphasia and cognitive communication disorders, and his federally funded aphasia rehabilitation research is focused on counselling, therapeutic games, and adaptive computer-based interventions. So thanks, Will, for joining us today, and I believe you are coming to us from not Pittsburgh, but Mexico.
Just for today. One time only.
I'm quite jealous because it was near freezing point overnight, and I'm sure it was not near freezing point overnight for you. I'll hand over to you.
Right. Thanks, John, for the lovely introduction. Can you see my slides?
We can. That looks good.
Great. So first, I'd like to start out by acknowledging all my collaborators. This has been a really large group effort. I'm really happy to have the opportunity to talk about today. So funding sources are the U.S. National Institute of Health and the University of Pittsburgh. I'd just like to give really sincere thanks to all my project collaborators. So that includes my study co-investigators, research speech-language pathologists and graduate students on the project, our Aphasia Community Advisory Board. And I'd like to specifically acknowledge Eric Meyer, my psychology collaborator in this work, and Alyssa Kelly, the research SLP and primary research SLP on this project, who made everything possible and everything happen. And so, outline for today's talk. So, talk about the issues we're trying to address and helping people, stroke survivors with aphasia, recover, address mental health issues that are huge barriers, talk about the background and rationale for the current work, including why we're focused on acceptance and commitment therapy, or ACT, and why we've chosen to combine it with communication strategy training. Then I'll spend the rest of the talk today talking about the specific pilot project itself. So the project aims, our methods, results, discussion, and future directions. And so thinking about stroke survivors, mental health has been recently designated as the #1 recovery priority of stroke survivors. And this was in a recent large-scale priority setting initiative in the UK. And so thinking about stroke survivors overall, say mental health is their #1 priority. But we also know, in addition to that, that stroke survivors with aphasia are disproportionately impacted in terms of mental health. So stroke survivors with aphasia are at disproportionately high risk for psychological distress, depression, and anxiety. And they often report that their emotional needs are not being met. One reason you could think about, why is this happening? Why is it folks with aphasia disproportionately impacted? Is it seems like there's these vicious cycles that can happen between mental health, experience of communication disability, right, which then affect life participation, further loss of identity, and ultimately motivation for recovery, motivation for treatment, right? And so these things can feed one another. So if somebody's struggling, they have low mood, depression, they start to withdraw a little bit more, then communicating becomes more burdensome, harder to do. They stop practicing applying skills. They stop believing that they can actually recover or improve, which in turn makes everything worse and harder. Right? And so it really seems like this idea of a vicious cycle between mental health and communication disabilities, painful and something we really, really want to help address for this population. And so the main position statement here that my colleagues and I have adopted, certainly I've learned and heard from others, is that given the reciprocal relationship between mental health and aphasia recovery, interdisciplinary and mental health services need to become a standard component of comprehensive aphasia rehabilitation. A really nice version of this position statement was by Dr. Miranda Rose in her recent Elizabeth Usher Memorial Lecture. And what we mean by a standard component is, this doesn't mean that every stroke survivor with aphasia needs mental health services. These issues are so pervasive and so common that it needs to be part of the assessment and treatment plan. Just like not everybody with aphasia has comprehension deficits, but we certainly think about comprehension and specifically address comprehension in comprehensive care when that help is needed. And that to do that, I really appreciate Dr. Ian Kneebone's conceptualization of STEP psychological care for stroke survivors and those with aphasia, where we can think about different people need different levels of support and different options for support. And so really need a wide-ranging menu. One level of care isn't going to work for everybody, but we need evidence-based and effective options for different types, right? And that's what I really like about, academia can be competitive. It's really hard to get research, but we don't have to compete. If we try to build lots and lots of successful options for different people, we can really work together on this, and I really hope we can, right? And so this is what we're trying to do, and this is what we believe. This mental health needs to become a standard component. We need to develop this menu of options. And currently, it's just really not available. And especially I can think about certainly not available in the United States. Mental health professionals, and you think about who's going to provide mental health services to stroke survivors with aphasia, mental health professionals would be the go-to, right? But often they'll report feeling lack of training and preparedness to actually provide these services, especially behavioral mental health. So this idea of, oh, well, this is a person who might have, pretty significant communication difficulties. Can I really do talk therapy with somebody who struggles to communicate this much? Right. In addition to these kind of concerns about training or appropriateness, at least in the US, mental health providers are already totally taxed and burnt out. So there's been a huge increase in caseloads and demands post-COVID-19, increasing wait lists, increasing client severity. And so we definitely need to increase services and figure out how stroke survivors with aphasia can get more help and support. But it might be hard to convince a burned out mental health professional to take on an entirely new complex caseload when they're already struggling to help the people they already know how to help. And so we should forge forward. We should figure out solutions. Mental health professionals need to be able to have the training and support and preparedness to do this, but we also need to think about other options as well, just pragmatically. And so that's part of why I've really thought about the importance of seeing if we can get speech language pathologists to help address this gap in counseling services for stroke survivors with aphasia. A lot of this work, my interest in it comes from my own clinical experience. as an outpatient clinician, where I ended up doing tons of informal counseling because I might have, good treatment plans, good strategies, some nice drills. But if somebody's in a moment of emotional crisis, none of that matters unless they have the help and support they need. And so as I realized how much this happened in sessions, if I didn't shut it down and how much folks needed it, I became increasingly interested in the counseling role of SLPs and how to do this appropriately and hopefully rigorously with good support. Right. And so reasons to think about why SLPs might be good providers to help to provide these services. Stroke survivors with aphasia are already on our caseloads, right? And so it's not taking on a new patient population, it's working with them with a new set of skills, right? SLPs, we already have the expertise in supporting communication and making these folks feel heard and understood, which is non-trivial in terms of forming a strong therapeutic relationship. And that the scope of practice, at least speaking towards the US, clearly includes adjustment counseling when an individual has communication deficits. And so you pull all this together, and SLPs could be great providers for kind of level 1 or level 2 step psychological care. So is general support, psychoeducation, emotional support for anybody who's struggling after stroke and living with aphasia, up until more specific adjustment counseling, as long as there's professional support from somebody like a psychologist, right? And this is kind of the scope and the role that we've been conceptualizing for the current project. But there's barriers here as well. So just like the mental health professionals, SLPs often report lack of confidence in training. So not feeling prepared to kind of provide this sort of service, despite the scope of practice and the clear need for these things. And some of that's related to limited counseling training. Like at least in the US, less than half of our speech language pathology graduate programs can have a dedicated counseling course, and it just has to be kind of worked in on the sides if a program doesn't happen. And then an additional factor is that this, lack of training, support, confidence is we also don't have much of an evidence base at this point. Thinking about counseling for people with aphasia with SLPs as primary providers of those services. Really nice counterpoint of that, or a clear example of where some of that work has started and has been done is Sarah Northcott and colleagues' work adapting and validating solution-focused brief therapy. So really promising, but still pretty initial work, but does show that SLPs can provide this role as a primary counselor. And so this is where we are. And so our intended project contribution is to develop a version of acceptance and commitment therapy for aphasia. And our version is an integrated counseling and communication strategy training for SLP primary providers with psychologist supervision. So something that an SLP could do to offer level 1 or level 2 steps to care. The idea is that hopefully will help contribute to the evidence base over time, and it could ultimately serve as a basis for workforce training. But some questions here at this point would be, well, why did we choose acceptance and commitment therapy? And why did we choose specifically to combine it with communication strategy training in an integrated intervention? And so I'll tell you a little bit of background about ACT. So ACT is a modern third generation psychotherapy that has a really strong mindfulness component. It promotes mental health and psychological well-being by improving their construct of psychological flexibility. And I'll talk a little bit about what that is, how it's conceptualized, and how it's addressed during treatment. ACT is about helping create a willingness to accept and stay in contact with uncomfortable experience, not for its own sake. Nobody wants to feel emotional pain or discomfort. But sometimes it's necessary if we want to live deep, rich, meaningful lives. And instead of a focus on symptom reduction, which is great, it's helpful, it's a really good approach up until you hit that limit of how much you can address or reduce. That's where ACT kicks in. So instead of just trying to reduce or eradicate unwanted symptoms, ACT seeks to shift the relationship to these unwanted painful experiences so that they don't serve as barriers to value-based living. And this is the part that when we were trying to think about, well, what would be the best approach if we're trying to develop counseling for stroke survivors with aphasia? This is the part I got really excited about because we know that, you know, if somebody has aphasia going into the chronic stage of recovery, they're really, really likely to live with some level of aphasia for the rest of their lives. And this isn't something that it seems like we have cures for at this point. I really hope that those come along soon, and I'd be happy to find other things to do with my professional life. But at this point, this isn't something we cure. And so if aphasia is a really painful experience, if the struggles with communication breakdowns continue to have this negative unwanted effect, we can't make that go away. And if the only solution is to try to eradicate or manage those symptoms, we're always going to come up against that wall. And so the core idea about shifting the relationship to these symptoms so that people with aphasia can move forward with meaningful lives, that's a really, really key element here and one that we're really excited about. Other reasons we've been working with ACT is it has excellent theoretical support and evidence base. So from a psychometrics perspective, the construct of psychological flexibility has some pretty good support, and it's clearly a modifiable psychosocial factor. So it's something that we can do something about. So people can actually become more flexible, which is a great thing if we're thinking about this as rehabilitation professionals and trying to figure out what we can do. And that this construct of psychological flexibility has also been established as a clear causal mechanism of action. So when people go through ACT, it often leads to clear improvements in psychological flexibility, which directly mediate any gains that people see in terms of improved outcomes like functional disability, right? And so that the reason ACT is working is people become more flexible, which then reduces the impact of the things that they're likely struggling with. In terms of evidence base, there's been over 1,000 published randomized control trials to date on a number of different populations and disorders, things like depression, anxiety, PTSD. A recent meta-analysis by Gloucester and colleagues, I think summary work from about 12,000 research participants found that ACT, good results for ACT overall, tend to be superior to treatment as usual, waitlist controls, and generally superior to active control conditions as well, including other types of psychotherapy. And so pretty strong evidence at this point. And there's been some promising preliminary research in communication disorder related areas. So some early work combining ACT with compensatory training found improvements in psychosocial functioning in people who stutter. It's been found to reduce depression in stroke survivors. And a really recently published pilot study by Patchwood and colleagues found that ACT was actually feasible to deliver to stroke survivors with aphasia in an online group format. So lots of reasons to be hopeful, to think that this might be an effective approach. I think it might actually work for this population. And again, the whole point here is ACT is about improving psychological flexibility. There's different ways to think about this construct and how ACT addresses it, but one of the frameworks I really like is from Russ Harris. So using kind of, this is called the triflex model. Russ Harris has a lot of really nice accessible resources if people are looking for kind of a beginner start to acceptance and commitment therapy. And so his version of the model has these three main fully interactive components. So each piece affects the other. It's all about this core of improving psychological flexibility as a whole. It's about helping clients open up, be present, and do what matters. And so with open up components, this is about helping people accept, right? So allowing for the presence of uncomfortable thoughts, feelings, internal experiences without unnecessary avoidance or defense. Another aspect of opening up is cognitive defusion. And so this is this idea of unhooking from thoughts or internal experiences. And so when we really struggle, when we're really upset, Often we get this kind of tunnel vision where the desperation feels like you can't see any other alternatives. If you're having, really negative internal thoughts, really uncomfortable experiences, it feels like there's nothing you can do and there's only one option, things like that. And so the idea of diffusing from those is that you don't make them go away. If somebody's really hard on themselves and having a lot of negative thoughts, they're really hard to totally eradicate. They're just going to keep popping up, right? But there's a chance instead of just eradicating the negative self-talk, you try some of those skills when it keeps coming back. An alternative is to defuse from it or unhook. And so maybe these thoughts are just words, stories, impressions passing through our heads. They're certainly not orders. So they may or may not be true. And so, right, it's just radio doom and gloom again, right? There's that channel where I get really hard on myself. And so that's still happening, but not in a way that totally directs behavior and keeps people totally stuck. And so ways that ACT helps folks accept and diffuse are usually experiential exercises or metaphors. And so, yeah, this idea of like it's a radio, right? These negative voices, yeah, that's just the radio doom and gloom. It's just going through my head again. That would be a metaphor that helps people diffuse. Another one of these key main components of psychological flexibility are the aspects of helping clients be present. And so one is trying to help them learn to stay in contact with the present moment, even when that's uncomfortable. And this is really mindfulness and mindfulness practices. So fostering non-judgmental, present moment awareness of experience. And another aspect of this, again, these are all fully interactive. Usually given exercise might address more than one component. These things aren't about delineating, they're about having a perspective about what you're trying to focus on and help people with. Right. So another piece would be then thinking about myself not as a context, right? So seeing the self as the space in which my thoughts and feelings occur, the space where my pain occurs versus the content itself. And so maybe a metaphor for that is, my thoughts and sensations are like weather, right? So sometimes it's beautiful and sometimes there's clouds and storm, right? And I can really identify with being the clouds, but maybe all the way through, I'm the sky. I can be the clear blue sky, right? Weather comes through, but I'm the context where that weather happens, right? And so examples of therapeutic approaches here are meditation practice, other mindfulness exercises, talking through metaphors, and other experiential exercises. And then the third component is helping clients do what matters to them. And that usually involves helping them clarify and understand their own personal values, and then actually acting their lives consistently with those values. And so in the ACT model, values are just what we most want to stand for in life, right? Simple, usually like one word or a short phrase. So for me, being loving, being kind, living with integrity, helping, being of service, right? Those are some of my own personal values. And then when you get that clarification, right, if you can put what you most deeply believe in and care about in just little words, then they're not short-term goals, right? They're directions in life. They're what to orient to, right? And so a value can't be permanently achieved. It can only be pursued. But you can come up with goals and concrete actions in your life that are consistent with living your values, right? And that's where the rubber can really hit the road and act, where we can see that all the pain and the struggle and getting hooked is coming at the cost of us actually living a deep, rich, meaningful life, right? And so this idea of committed action is, again, living out our values in our own lives through concrete behaviors and actions. And so therapeutic activities here is working with clients to help them understand what their own values are and then helping them actually act on them. And so one way that's often framed is this idea of a bold move. So, okay, so one of your values you've been telling me about is being loving and that your family is really important to you, but it's hard a lot of the time. So for you right now, today, what do you think is a way that you could act with love with your family? What's a way that you could live your value of being loving with your family today? Let's figure it out. Let me back you up so you can figure out something that you can do that's you living your values. right? And so those together, so opening up, being present, and doing what matters is again about this creating a space and clarity so people have a chance of responding to their lives differently, right? That's this shifting relationship to symptoms so that we're not just driven by our fears or our pain. We can actually live a meaningful, deep life. Some other concepts that are really helpful, especially thinking about how to apply this and support folks who have aphasia. I really, really like this concept of workability. Workability is great for perfectionists, and it's a great replacement to judgment. And so it's just about, are things working for you or not, right? Is what you're doing working to make your life rich and meaningful right now? The answer is yes, then it's working. We'll call it workable. There's no need to change it. But if the answer is no, you don't have to beat yourself up, but you can just acknowledge that it's not working. It's unworkable. So what can we do together to help you figure out alternatives? How can we make things workable for you? Another really helpful concept from ACT is this idea of experiential avoidance. And so living organisms do not want to feel pain, right? Pain is a signal to avoid, to not feel, right? Something's happening that we don't want to happen as living organisms. And so it's the most natural thing in the world to try to control, avoid, suppress, or eliminate unwanted internal states. The problem is that this can lead to behavior and outcomes that are really inconsistent with values or goals and ultimately make things a lot worse. And so a really common example of this would be drug or alcohol abuse and addiction, right? Where there may be trauma or emotional pain that in trying to address that through alcohol leads to temporary relief and an ongoing perpetuation of suffering, right? Ultimately makes things worse, not better. So that would be an unworkable strategy. Another example that's really, really common for folks living with aphasia is withdrawal, because it can be really, really painful to live with aphasia and try to participate socially, try to communicate. And it's hard not being understood. It's hard being in a group and people not understanding what you need. These can be really painful experiences. And so the most natural thing in the world would be to avoid them. But at what cost? That can start to become unworkable because it can feed these vicious cycles and it can make it harder and harder to live a life that's rich, deep, and meaningful for you. Right. And so thinking about what to target and how to go about it is, again, control strategies are natural and it's great to use them up to the point where they're workable, but notice when they're not. And so ACT really tries to focus on helping clients reduce experiential avoidance when it becomes too costly, when it's ineffective, and when it becomes really life distorting. And you can imagine all sorts of examples where that happens really commonly for individual stroke survivors living with aphasia. So far, you can see some of the reasons why we're really excited about using ACT to help stroke survivors with aphasia. So this focus on shifting relationship to symptoms is key. This idea of focusing on flexibility, giving people alternatives and clarifying what's meaningful to them, how they can live their life, even if the whole context of their life has changed, right? They might have been working, now they're not. They would have had all these abilities and eloquence, and now it's a struggle. But the values can stay the same. And so there's still ways to live values in the current context of their life if they can be flexible. Right? This is, again, why we're really excited about using this approach for this population. But the other piece of this is, why intentionally did we decide to combine ACT with communication strategy training? And that's at its basis is, like I was saying earlier, there seems to be this really clear reciprocal relationship between communication disability and mental health, right? And at its core, when we can't totally restore language functioning, people are living with communication disabilities, but most folks have the potential for communicating better with flexible approaches or alternative approaches to communicating. If they can't say it, what else can they do? There's lots of things that are possible if they're willing, right? So at its core, focusing on functional communication is flexible communication, right? So psychological flexibility should help with that. And on the other side, addressing communication disabilities, ameliorating their impact, should directly support mental health as well. The place where we've really tried to lay this out is this is our developed ACT for Aphasia. program theory. And so the key intervention components of this version of ACT for Aphasia are all the ACT pieces I've talked about so far. So mindfulness practices, conversation, experiential exercises, value consistent action. And on the communication strategy side, focusing on really simple, practical communication strategies that are really patient-centered and patient-driven. So simple multimedia communication strategies. So if you can't say it out loud, well, what else can you do? Could you gesture? Can you write single words? What's going to work for you? Another category of communication strategies we focus on is something that another work I've developed calling system calibration. This is this idea of if somebody really understands their current language profile, their strengths and weaknesses, what it means for them to have aphasia and how it actually works, they can make best use of their current cognitive linguistic system to produce language or to understand, right? And so it might be as simple as, oh, when they start to get all this increasing fatigue, semantic interference over time, they can notice that state. And if they slow down, they take a breath, they say, wait, give me a minute. They might be able to keep communicating verbally really well. Whereas if they can't do that, they're going to break down. And so those are examples of trying to help people calibrate better to their current system capability. The third area is communication self-advocacy. And so if people can talk about their aphasia, they can self-disclose communication disability. They can actually advocate for their needs and get reasonable accommodations in society. But that's a big if, and that's really, really hard. And that requires a whole lot of vulnerability and bravery, right? And so if we can help people do things like make an aphasia card or come up with scripts that talk about what their own specific needs are, or really ask a stranger to repeat themselves, things as simple as that, there's a chance for functional communication to happen, right? And so those are kind of the areas where we focus on. And you can see those are the key components of this integrated intervention. And then you can see they have direct effects and synergistic effects and what we're trying to change overall. And so the ACT component is all about increasing psychological flexibility, which then, whereas the communication strategy component is about giving them, helping them acquire better communication skills and building up this kind of individualized communication strategy toolbox. Now, synergistically, if we give people better communication skills, that supports their understanding and being understood during this talk therapy, right? It also supports them actually being able to participate in their life, doing this value-based living, these bold moves, when they require communication, which is many, if not most, value-based activities for these folks, right? And so the communication skills training essentially provides access to the core components of ACT. On the other side, improving psychological flexibility can increase the willingness to actually use these skills in real life. Like telling a stranger you have aphasia and what you need to communicate, right? That requires a lot of psychological flexibility and willingness. But if people are actually willing to use this, they're actually willing to use their skills with their family, they're actually willing to try, they're actually willing to participate. What we know from the learning and rehabilitation literature is like that's exactly what you'd need to consolidate a skill, to retain it long term, and to generalize it to new contexts. And so increasing psychological flexibility, we hope, would then actively support consolidation and generalization for these skills. And together, since these things are synergistic, people might become more flexible, shifting their relationship to their symptoms, increasing their willingness, increasing their life participation. This together, we hope, will reduce psychological distress, improve functional communication, life participation, quality of life, and ultimately help folks successfully renegotiate their identity and figure out what their version of thriving is, even if they end up living with a chronic disability that never goes away, right? This is our hope. This is the way we're conceptualizing what we're trying to do. And here, in the last section, we'll talk about our work so far. So we've recently completed a phase 1 pilot study funded by the US National Institute of Health. Our aims were 1, to collaborate with an interdisciplinary research team and aphasia community advisory board to develop and refine an ACT for aphasia treatment manual, and then to establish the intervention feasibility, trial acceptability, and preliminary effect sizes. of this version of the intervention. We used a successive cohort study design, which is a really nice approach because you don't have to have everything figured out all at once. And so here are the steps we went through. We created an initial version of the treatment manual, tested on a small initial cohort of 5 stroke survivors with aphasia, then did lessons learned, post-treatment interviews, talked with our advisory board, figured out what changes we might have to make the intervention better, tested on a second larger cohort of stroke survivors with aphasia, and then assessed our study outcomes. And so the primary outcomes for this phase 1 study about looking at intervention acceptability and trial feasibility. And the secondary outcomes are just a really preliminary look at initial effect sizes on patient-reported outcomes of communication, mental health, and quality of life. And then, having gone through everything, we then looked one more time to see if there's other ways we could improve the intervention based on what we've learned so far. We did a lot of the nice thing about this project, it had lots of interdisciplinary research and community engagement. And so folks on the research team include represent speech language pathology, clinical psychology, mental health counseling, and occupational therapy. And their aphasia community advisory board includes 5 stroke survivors of aphasia, 2 care partners, and together they represent leadership roles in a total of 5 US-based aphasia or stroke recovery nonprofits. That's something that we feel really good about, because when folks from the community step up and show us that they're ready to lead, they're ready to contribute, they're ready to show what they think needs to happen, it's really nice to connect with them and give them the power and to have a real impact on what happens in research and society, right? So our advice is, if people are already leading, give them opportunities to lead more. And here's how we engaged our community advisory board in the current project. So for initial manual development, we did some additional initial training and orientation of the study, included both synchronous and asynchronous video training, individual feedback interviews about thinking about what we might miss, what we should do to do the best version possible, and then group integration meetings where we kind of worked through and talked about everybody's ideas. Then in terms of actually developing the specific materials to use in the treatment, we had optional weekly office hours where anybody from the board was welcome to come check in with us, see what we'd been working on, and give us tips for improving it and making it more aphasia friendly. Then at each subsequent stage, after we finished each cohort, we'd send out the board summary videos of what happened, questions, initial lessons learned, and then talk through in full board meetings to make sure we had the advice to move forward and improve things. In terms of participants for the study, we worked with adults with aphasia, subsequent left hemisphere stroke. Everybody had to be community dwelling. With the initial cohort, we were just looking for folks in their first year after their stroke. And the idea there is we wanted to make sure that whatever we developed would actually work for people really early on. Never thought it would need to be exclusive to that, but if it could work for them, the hope is to really shift recovery trajectories long term. Helping people accept and become more flexible early might really, really change the amount of struggle and suffering folks go through and their growth and recovery. But we'll talk about why. And with cohort 2, we shifted to no restriction time point onset. This was really from strong advice from the advisory board, the community advisory board, because they're like, I wouldn't have been ready. Different people are different processes, different recovery speeds. This early on, don't restrict your enrollment criteria, really see who it's going to work for and how. The final sample for our participants, we had 5 participants enroll in the first cohort and a total of 15 participants enroll in the second cohort. Of those, 19 completed the study as a whole, and reflected that in terms of exclusionary criteria, I just skipped over in the last slide. One of the key ones is that we excluded folks that had severe auditory comprehension deficits, given the talk-based nature of the treatment. And because of that, I think that skewed our sample a little bit, where most of the folks had moderate to milder aphasia severity. In terms of our results, we developed our treatment manual. So we started with a manual that It was a training manual for the U.S. Veterans Affairs healthcare system that our collaborator, Dr. Meyer, helped develop and adapted it into a 10-session intervention for people with aphasia. The core components I mentioned earlier in laying out the program theory, but about ACT, so mindfulness training, values work, aphasia-friendly education about ACT concepts, and helping participants set up weekly bold moves for communication and life participation that is consistent with their core values. We also did tailored communication strategy training. And I'd be happy to answer questions about more details about the protocol. In terms of refinements and changes we did over time with this successive design, is that fortunately they ended up being fairly minimal. So after the first cohort, really the recommendations was to streamline the materials so that there was less paper. And so we went from having kind of printed out handouts or slides talking through concepts to really streamlined handouts like single pages, double-sided for a key piece so that there was just less paper for the clinician and the participant to work through. Clarified some options for daily mindfulness practice and expanded the enrollment criteria for any point in chronic recovery, as I mentioned before. Now that we've finished everything, thinking about additional revisions, I think that moving forward, if we can continue this work, we want to add 2 additional booster sessions. And that's mostly because many of the participants in post-treatment interviews felt like, oh, things have really started to click. I just wish I had more time to consolidate and apply what I already learned. And so we'll hope to add 2 more booster sessions to the protocol moving forward. I have examples of treatment materials I might be able to show, but I'm just mindful of time. I want to make sure there's plenty of time for the Q&A, right? And so these are examples of what bold moves might look like, what communication strategy toolbox might look like for an individual, but aim to results. Overall, we found good acceptability as measured by client satisfaction. So 29.7 out of a maximum of 32 points. So people were really satisfied with the intervention overall. And we also found good trial feasibility. So we had 18 months of active recruitment and/or data collection over the overall study period. And in that time, we had 53 stroke survivors with aphasia referred, 27 consented and evaluated, 20 enrolled, which exceeded our benchmarks, what we were looking for. And only 1 participant withdrew, leading to a very low attrition rate of 5%. In terms of patient-reported outcomes, again, these are really preliminary. This is phase 1 work. It's not intended to really evaluate effect sizes, but we can get this initial look as a way to move forward and think about evaluation strategies. This is just simple pre-post testing of patient-reported outcomes in the absence of a control condition. And here, we found medium effect size improvements for quality of life, psychological flexibility, and resilience. We found large effect size reductions in psychological distress, and we found small to medium effect sizes for measures of communication. But I just really want to drill in what it meant for this large effect size reduction in psychological distress. So we used a measure called the Kessler K6, which is a really widely used diagnostic measure of distress, where you can use it to screen for mental health. And this is actually the whole measure. So we ask folks, during the past month, how often did you feel nervous, hopeless, worthless, restless, or fidgety, so depressed that nothing could cheer you up, or that everything was an effort? And at baseline, overall, the group showed moderate psychological distress. So 1 participant with severe distress and 12 with moderate overall. Post-treatment, on average, the group showed minimal to no distress after treatment. So many folks showed 5 showed moderate psychological distress, and everybody else showed minimal to no distress. And one little point here is that since this is early phase 1 work, and we're thinking about both level 1 and level 2 step psychological care, we did not enroll people who only had mental health struggles or endorsed them. We enrolled anybody with aphasia who wanted to do the trial. So this is just another data point that shows how pervasive mental health issues are for this population. But it also shows some really nice initial hopeful work about being able to address that. And just some treatment quotes and examples. I'll just highlight one example of what did these bold moves look like? What are the sorts of changes people were doing, reporting their lives? Where is this change coming from? And so a bold move that our participant 19 set was to sit in the common area and interact with their neighbors. And so the last time that she did this, she got stuck on some words and felt embarrassed. She hadn't been back to the common area since, but she tried it this time. And her outcome is she went one day, ended up there with her neighbors for 2 hours. She said it helped her feel like a member of the building community again. She found herself getting stuck occasionally, and in those moments, she sat quietly and listened, but at other times contributed to the conversation, which felt like a balance that still moved her towards her values, which in this case was about connecting with others, right? And so these are the sorts of changes participants were making in their lives. So overall, we showed good intervention acceptability and feasibility for subsequent clinical trials. The phase 1 study was not designed or powered to actually evaluate outcomes or effect sizes, but we do feel like we found some promising initial findings. So medium to large effect sizes for reducing psychological distress, improving resilience and quality of life, and some small to medium effect sizes for improving communication function. So some of the big takeaways from this trial is that folks can do this, right? So stroke survivors with aphasia and SLPs can handle this level of complexity and this type of counseling approach, but support from our supervising psychologist, Dr. Meyer, was key. The reason for that is this idea of, even the intervention is called ACT for aphasia, but what do we mean by that? Do we mean ACT to address the disorder or ACT to help people who have aphasia? Because that answer is totally different. And people are holistic, right? And so what happened in the trial is people would start to have a counseling relationship with one of our treating SLPs. Other stuff comes up, right? So some people wanted to start setting goals about drinking less, or started talking about how their aphasia really reminded them of all their previous history of trauma and abuse, right? And so we don't want to draw boundaries in people's recovery and counseling. We need to think about step psychological care and know when to refer and what support to get. And so that part's really, really key, is that most of what people talked about, most of what they needed help with was totally within the SLP scope of practice. But when it wasn't, we needed to know what to do and how to refer, how to support them, and not just shut it down. The other big takeaway, so we have really promising pilot results, which justifies moving towards next step would be a phase 2 randomized control trial, where we want to compare the effects of the intervention versus the active control. And the way we want to do this is this is kind of like a show and tell. I was really happy to find the new updated UK Medical Research Council framework for developing complex interventions. I think this is a really, really helpful tool for our field, because it thinks about these components. And clinical trial development research is still this linear phase. You go to phase 1 to phase 2 to phase 3, at least in the NIH model that I'm familiar with, right? But there's all these different components to think about. And so I'd really suggest folks check out Skivington et al. This paper, thinking about what to do at each stage of the intervention. So you can do feasibility testing, formula evaluation, intervention development, implementation, and really thinking about why your treatment matters and how it's going to fit in the world. And you can think about all these key components and how they interact at every stage of intervention development, with the ideas that you'll have better targeted, more effective interventions that have a much better chance of being implemented long term. And so the place where we're trying to go is, if you see on the far left, this is this phase 1 trial we just completed that I just talked you through. So good pilot results, good chance to move forward. What we're hoping to do next, if we can find the funding, is a phase 2 randomized control trial, right? And so we can do formal evaluation. We can see if it's feasible to move to a phase 3 definitive RCT. And we can really think about all the different components and how to actually make this work in our focus in US healthcare systems. Because we need to start thinking ahead way earlier about implementation if we want to make a real difference in the real world. The long-term goals is we're hoping to eventually be able to evaluate this work using phase 3 randomized control trials and maybe hybrid implementation research. But the reason this is really important in our US practice context is that it gives us a chance to actually change Medicare reimbursement. And so adjustment counseling is within the scope of practice for speech pathologists, but it still might be hard to bill for. And so if we can really get the highest level clinical trial evidence, that would be a place where SLPs could actually specifically bill for these services, having been well trained or maybe certified in a way that gives access to different insurance pools and gives stroke survivors with aphasia better access to care that's sorely needed right now. So this is where we've been, and this is where we're thinking about for the future. So thank you for the chance to opportunity to speak with you all. We really care about this work. We're really hoping to move it forward. Be happy to answer any questions.
Thank you so much, Will. It's I can see you value this area of practice, and it makes sense why it's such a essential need out there. I mean, perhaps if we could say that there's one thing that if we could say that everyone with aphasia gets this one thing, I think psychological care might be it. And you're clearly doing very thorough and collaborative work to get this into hopefully funded practice, right? Let's start with the questions in the chat. Elliot Pex asks, he says, thanks for presenting this valuable work, William. I would be interested to know more about acceptability and feasibility of ACT for clients with more severe aphasia. Has this been explored by anyone? Are there any indications whether it could be modified for those with more severe presentations?
Yeah, I think this is the same thing where I have to see Dr. Kneebone in the chat, right? A lot of the modifications that he laid out as 2016 paper for CBT apply here as well, where our sample, again, it trended much more towards moderate to milder aphasia, but we had a couple folks with more severe aphasia, and it still works up to a point. I think one of the key parts is that we can't assume that somebody can't do it just because of what their scores look like. Long term, I think, if we had data set of hundreds of folks and much stronger data set to do prognosis, I'm open to that, but I don't think we're there yet as a field. And you'd be really surprised. One of the things that I think we learned that really helps is that somebody doesn't have to tell me what they're thinking to think. And so working through doing, guided discovery, patient-centered work, some of these more abstract components can certainly happen in this quiet interior space that we don't have access to. That's where I think you can get farther with more severe folks than possible. Certainly, this is something we'll be looking at if we can get to the phase 2 trial about, much more stringent thinking about better eligibility. But I wouldn't preclude it yet, especially because things like the mindfulness components can be so profound for folks.
Yeah. I mean, you said that sort of severe auditory comprehension was an exclusion criteria, but one thing that came to mind listening to you was how difficult it can be for people, and it varies person to person, but to describe their inner monologue or their inner thoughts. And, I can imagine that is only more difficult depending on the expressive ability of someone with aphasia. Did you find any impact of that in the treatment, or you did find ways around it?
Yeah, I mean, so a lot of the same kind of partner-supported communication techniques, right? So to the extent where somebody can endorse things, and it worked a lot with the treating team about just being like, okay, you don't have to feel like you completely know what somebody's thinking, as long as they're giving information to you that what you're going through is valuable to them, right? But then you still do the supports, right? So if you're trying to come up with you talk about content and so here's a concept again, diffusing, or a chessboard metaphor is like you're not the pieces on the board, you're the person watching the whole game play out, right?
Yeah.
Somebody might not be able to tell you what that means to them, but you can see in their body language if it resonates. And then you could ask, first, and so now moving on from there to try to apply this in your life. Let's try to do some forced choice options, different things. You can use some of the same skills, but the more severe you get into the comprehension expressive side, the less pure abstract talk-based therapy you can do. I think my main takeaway point is don't assume you can't do any.
Yeah.
Try to see if you can do a little bit more, because you can tell just looking at their body language, their emotional state, if they think it's valuable.
I suppose unfortunately, the status quo for many people is no treatment, no psychological care. So, yeah. Next question is from Dana Wong. Thanks for a great talk. Yeah. Oh, all right. Chatbot just moved. There are many synergies with our Valiant program, which combines ACT with cognitive rehabilitation. To what extent are family members and other communication partners involved in the program? And what do you think were the trickiest parts of the program for those? Well, let's start with the first question. To what extent are family members and other communication partners involved?
Right. So I'm smiling because this is one of the places where the community advisory board kept me from making a silly mistake early. Because this is a one-on-one intervention. I was thinking about, internal review board, ethical constraints, who counts as a participant, who you'd be billing for in the real world someday, right? It's like, oh, this is a one-on-one therapy. And as soon as I laid it out, they're like, yeah, but wait, what about the family? What about the partners? If you're trying to help people, how could you do this without making space for people to be involved? And so even in the first version of the manual, we made a specific invitation to allow care partners to attend, specifically like at least one session. We kind of want to make sure that people have this personal safe space for counseling and try to get the dynamics of how much it would be helpful for both people to be there, but at least one invited folks to attend. And then try to do a lot of warm handoff about, oh, let's talk about the end about kind of takeaways, next steps. Because again, a lot of this comes down to this idea of bold moves. So here's what this person's saying they want to do this week to live their values. Hey, let's talk to your partner about this, right? And so trying to do that warm handoff communication, that happened really consistently. And then it really depended on the couple, the dynamics. Some people said, no, I never want them there. Some people had them participate in a lot of sessions.
Yeah. The second part of Dana's question we might have already touched on, but I'll read it anyway. What do you think were the trickiest parts of the program for those with moderate to severe aphasia, and what further modifications do you think may be needed?
Yeah. So I'd say some folks, again, it varied a lot because some folks with more severe expressive aphasia could do many of the components really well. I'd say one of the pieces like trying to help come up with really successful, meaningful, bold moves, right? So figuring out what to do and how. That was something that struggled with. We didn't formally evaluate cognitive status, but there was a couple individuals I'm thinking about the research that Catherine told us about who had some concomitant cognitive difficulties. So helping them get to the place where they had concrete value-based actions to take, that was a really big struggle for them. Yeah, those are kind of my first things that come to mind.
Yeah, thank you. Sarah asks, says, thanks for a great presentation and the incredible and timely work you and your team are doing. Does this program manual have ideas of how to accommodate for culturally and linguistically diverse populations, or when working with an interpreter?
So probably not enough, right? One of the things I went by the participant slides pretty quick. We've been trying to do a better job of even enrolling representative samples to, we're evaluating acceptability, feasibility. 18 out of the 20 folks enrolled were white and 2 were black, and that is not represented in our current samples. So, right. So even just thinking about who we're doing the acceptability testing on, we're already having issues. And that's despite some pilot funds and very intentional additional outreach. I think so we should do better. I think the metaphor work may or may not hit, right? So yeah, I mentioned this chessboard analogy. If you don't have any experience with chess or it feels very othering to you, that's not going to be a helpful metaphor for you. I think the one thing we did really try to do, and it's a core tenet of ACT, is everything needs to be patient-centered, and everything, the therapeutic relationship is between equals. So even though we had a treatment manual and a binder full of exercise and handouts, we try to make that really clear from the start and continuously. One example of where we would make a clear adaptation is that many of the participants we had very strong religious beliefs. I'm remembering one in particular who meditation's not for me, right? As soon as she heard meditation, she was thinking Buddhism. It's just not
Mm.
line up with her own Christian faith. And so after a while, we realized, oh, well, all these exercises we keep giving, these mindfulness practices, they're just not for her. What about contemplative prayer, right? And as soon as we showed her this background and where it came from in her own religious tradition, it clicked.
Mm.
And she had this really profound change about seeing how this was just a different version of praying to her and had this profound change. And so that's the example of how we tried, but at this point, it's pretty piecemeal and definitely something we should think about moving forward.
Mm. We are probably not going to get all through these questions, but we might just run over a little bit and do a few more if you're happy to.
I would love
Uh,
to. I really appreciate the questions.
yeah, Sam Harvey's asking, thanks for talking about this important and promising work. I wonder if you think ACT for aphasia might be more or less suitable for particular individuals, and what characteristics might lend an individual to positive engagement and outcomes.
Oh, right. I mean, this is where I like the whole menu of options idea, where I feel like oftentimes there's these group level non-superiority of one treatment approach versus another, as long as you have a really well qualified, caring therapist, right? You're likely to make changes, but I think there's some individual fit pieces.
Mm-hmm.
And I can't comment yet on exactly who it doesn't work for, besides the folks that don't like the language and the framing and the focus on mindfulness, right?
Mm.
So the last participant I talked about was going to be one of those until we figured out contemplative prayer, right? And so how flexible you're allowed to be, how off script you're allowed to be is going to really, really change that piece. I remember, so client satisfaction, the reason the scores weren't a couple points higher is there was one participant who gave it a 13 out of 32. Everybody else was like 30 or higher. And he
Mm-hmm.
was like, I want drill-based treatment. I signed up for this, but I didn't want anything to do, like I didn't want anything at all like this.
Right.
Versus at least at this point. So again, in the real world, you offer something and let somebody decide about it, right? You need the menu. Here, at least the client satisfaction piece being pretty high across the board for folks who just signed up for a aphasia treatment study. Is at least hopeful that it could potentially be a good fit for lots of folks, if not everybody.
Mm.
But we'll need to see.
Yeah. Yeah. I mean, it's obviously personality and individual characteristics, not necessarily anything to do with stroke or aphasia, that might be the predictors. There's a question from Judy about what courses people can take to upskill themselves. I can say that Jazz Binder-Sakon has developed the CLEAR course, CLEAR, which you can look up. Do you know of any, Will, that are sort of publicly available right now for SLPs to upskill?
Specifically for ACT. I mean, I know that.
Any, I think, is the question, but ACT certainly would be a good one.
I mean, so Jess is the one I know about. I know there's like different continuing education in the US. Like, I don't think we have enough training yet. I mean, the way
Mm.
that we prepared SLPs to do the trial is they took the online Russ Harris's Act for Beginner course, and we had a psychologist who could talk through it with us and then have weekly meetings while people actually had a caseload, right? And
Mm.
so got an orientation, we had a treatment manual, and then kind of got started. So I think a lot of, besides Jess's course, I think a lot of it is non-specific to SLPs or just kind of one-off seminar things.
Mm. Yeah. Yeah, I think one answer is there's a fair gap at the moment, but there is obviously work such as yourself on its way. Look, there are more questions. I might send them to you via email. Unfortunately, we need to stop
Yeah, please email
there.
me. I'd love to respond. I see some more great stuff in here.
Yes, apologies, everyone. It's just a matter of timing. But thanks so much again, Will, for your presentation. Oh, that's more like it. It'd be great if everyone kept up to date with what we're doing through our social media, LinkedIn, Twitter, Facebook, and our blog. We're just finalizing the last few sessions for 2024, and we will continue into 2025. So we hope to see you at the next ones. Thanks again, Will.
My pleasure. Thanks for the invite.